Welcome to Pediatric Nursing. I hope you enjoy this course and your clinical course also. As you refer to your first day handout, you'll find the course outline and unit objectives. Also, the class schedule lists the chapters that are covered for each of the sections, as well as specific page numbers if there's information that's harder to find. Which of the following best describes why infants are at greater risk for dehydration than older children? Did you select the correct answer? The correct answer is infants have an increased volume of extracellular fluid. And because of this alteration in the extracellular fluid, infants and young children are at risk for dehydration and fluid and electrolyte imbalance. This slide has important information for you to know. The assessment of urine output in clinical practice is calculated in mLs per kg per hour, and we always want to make sure that the urine output is at least 1 ml per kg per hour. And for the administration of potassium, you probably remember that we never give it IV. It's always diluted in with an IV bag. And we want to ensure that the urine output is adequate before we hang IV potassium because it can lead to lethal cardiac arrhythmias if the potassium levels get too high. So again, if the heart or the kidneys aren't working well, that can lead to elevated levels of potassium, and that can lead to lethal cardiac arrhythmias. And I know you've been taught that in med-surg, and usually the students really remember that point that they've been taught. So do remember that for NCLEX, that's important information. Urine-specific gravity is, we want to check at every void until stable. So this would be any child that comes in with hypovolemia, dehydration, nausea, vomiting. We're going to be checking urine-specific gravity on them. And when we say stable, stable would be a urine-specific gravity of 1.010 to 1.020. And then we have to remember that infants are not able to concentrate their urine, so they do run lower urine-specific gravities. And we'll be talking more about urine output, how we calculate it. Also, we talk about signs of dehydration and that as we go on. So again, this is an overview slide with important information that you should remember, not just for your test, but also for clinical practice. Physiologic differences. We know that the kidney function is decreased at birth. They have a higher metabolic rate, also a greater body surface area. And if you recall from OB, you probably changed a lot of poopy diapers, so they have faster peristalsis. The immune system is decreased in young infants and young children, so they're more at risk for infections. And their thirst, they're not able to regulate, so they rely on parents and caregivers to provide fluids. And again, we'll talk about that as we go along. And then the lower esophageal sphincter muscle isn't fully developed. So this puts babies at risk for GERD or gastroesophageal reflux. So these are all physiologic differences that can contribute to fluid and electrolyte imbalance in infants and young children. This slide shows total body fluid. Body water percentage for weight varies with age. We know that newborns have the highest percentage of water at about 75% total body water. And then this decreases with age towards adolescence and into adulthood, where the total body water is about 50%. Here's another slide showing body water distribution. And we do want to remember, and it's highlighted in red, that infants and children, especially young children, have a greater percentage of fluid in the extracellular compartment. And you can see that listed in the slide over on the right-hand side, the differences in showing the greater percentage of extracellular fluid in infants and young children. And again, this decreases with age. So neonates have about 40% extracellular fluid, and then adolescents and adults have about 20% extracellular fluid. So what becomes important, I forgot about Mr. Slurpee here. So what becomes important is the major electrolyte in the intracellular fluid is potassium. And more importantly, is the major electrolyte in the extracellular fluid is sodium. And anytime there's an imbalance in sodium being high or low, there can be a risk for seizures. So we would want to implement seizure precautions. And again, the factor that plays into this physiologically is that, again, the major electrolyte in the extracellular fluid is sodium. So in infants and young children have a greater percentage of extracellular fluid. So if there's any disturbance in having problems with dehydration, nausea, vomiting, anything of the like, that can lead to loss of extracellular fluid and imbalances in sodium, and that can put them at risk for seizures. So the key point again would be to remember that the extracellular fluid, the major electrolyte is sodium, and if there's imbalances, either high or low, they're at risk for seizures, and we would want to be cautious and implement seizure precautions. This formula shows a daily fluid requirement. It's calculated on every child at the beginning of the shift. This information is also in your book. So the formula is up to 10 kilograms. The infant would receive 100 mLs per kg per 24 hours. And if the child weighs 11 to 20 kilograms, then the formula is 1,000 milliliters plus 50 milliliters for every kilogram that's above 10 kilograms. So you can see that the first 10 kilograms are already accounted for in the formula with the 1,000 mLs. And then what you're going to do is for every kilogram over 10 kilograms is multiply that by 50. And add it to the 1,000 mLs. And then if they're over 20 kilograms, again, the 1,500 mLs is already accounted for. And then you take 20 mLs for each kilogram above 20 kilograms. So if you just had an infant that weighed 5.8 kilograms, you'd take 5.8, their weight, times the 100 mLs. And so that baby would need 580 mLs per day. Now remember, these are minimal fluid requirements. They can get more than that, but you want to make sure that that's the minimum that they would get. If it was a child that weighs 15 kilograms, so remember again, the 1,000 mLs is for the first 10. So we're going to, if you take 15 minus 10, that would be 5 kilograms. So we're going to multiply that by 50, and that gives you 250 mLs. So then we would add the 1,000 mLs to the 250 mLs, and so that child would need 1,250 milliliters per day. And then an adolescent weighing 48 kilograms, again, the first 20 kilograms are accounted for in the 1,500 mLs. And the difference, we would take 48 kilograms minus the 20 kilograms, and that gives us 28 kilograms, and we're going to multiply that by 20 milliliters. So that gives us 560 milliliters. So the 560 milliliters is added to the 1,500 milliliters. So this adolescent's going to need about 2 liters of fluid, or 2,060 milliliters per day. Okay, so again, remember that these are minimal fluid requirements that a child would need. And it would also account for not just oral fluids, but IV fluids if they're in the hospital. So you'd want to tally up both the IV and the oral fluids for that. And then you also need to take into account their medical diagnosis, which we'll talk about in the next few slides, because if there's any medical problems, we may need to either go up or down on the fluids for that. Okay, so do make sure that you calculate out the fluid requirements at the beginning of this shift, because that's going to guide your care to see are they on target with getting enough fluids, or possibly maybe the doctor didn't order an IV and the child's not drinking, and you might need to ask the doctor and show them, the fluids that the child's got in compared to the fluid goal, and let them know that maybe we need an IV started. Or sometimes they've been on IV fluids and then they start feeling better and they're drinking more, and then you can have the IV discontinued. So again, it's going to guide your care towards what the child would need. So doing it at the beginning of your shift is really important. You don't want to wait until the end of shift. Okay. So as I mentioned previously, different health deviations or conditions that alter fluid requirements in which they would require 1.5 times maintenance would be fever, dehydration. They might have a diagnosis of hypovolemia, nausea, vomiting. They could have asthma, pneumonia, tachypnea. And then they're losing through insensible loss with these, as well as with burns. So we have to remember anytime that we have rapid respirations, or if our integument is disrupted, or if they have some sort of medical diagnosis where they have dehydration, fever, nausea, vomiting, diarrhea, these are all indications that we would go up on the fluids to 1.5 times maintenance. And I usually say any of the itises, like, so say a patient had appendicitis. We know that we want to rid the body of that infection that's going on in the appendix. So any of the itises usually are at 1.5 times maintenance also, with the exception of like a carditis or a nephritis. So if the kidneys and the heart aren't working well, then they're not going to be able to tolerate extra fluids. So again, really be thinking about what's the medical diagnosis, and do I need to add 1.5 times to the amount that you calculated based on the formula that was in the previous slide. Health deviations and conditions that alter fluid requirements for 2 times maintenance would be sickle cell disease, and if they have severe dehydration and they can't tolerate oral fluids, sometimes they require 2 times maintenance. So if it is a patient with sickle cell, generally what they'll do is they'll order the IV fluids at 1.5 times maintenance, and then you get the child to drink to 2 times maintenance. Okay, so that, again, it's really important that you do the fluid requirements at the beginning of the shift, because that's going to guide your care, and you can do teaching with the kids on how much they need to drink. Make sure that you tell them in numbers of cups, not just drink more, because more to me might be different than more to you. So always be specific in numbers of cups, and make it fun, and make games, and try to get the kids to drink more fluids. Health deviations and conditions that alter fluid requirements in which there's decreased fluids. They might generally decrease them to about 2/3 maintenance. Sometimes it's half maintenance. And again, I indicated this before. If they're having kidney problems, or if they're having heart problems, or if they're having increased intracranial pressure that isn't being managed by an external ventricular drain, then they might need to go to lower on the fluid requirements. Postoperatively, sometimes they may go lower on the fluid requirements. And then also with mechanical ventilation, because with mechanical ventilation, it's a closed system and it's humidified, and they're not going to be losing through insensible loss. So those are just some things to remember. As previously mentioned, we calculate urine output in mLs per kg per hour. So you divide the amount of urine that's in mLs by the child's weight in kilograms, and then divide that by the number of hours that the urine output was obtained from. So you could use an 8-hour total, you could use a 12-hour total, you could use a 24-hour total. You do want to make sure that it's just strictly urine, and it wouldn't include any diapers that would have stool, because sometimes they may have weighed that along with the urine, and usually they'll put a little notation that it's urine and stool mixed. But you'd only want to be accounting for the true urine output. The expected urine output, according to age, infants and toddlers are usually greater than 2 to 3 mLs per kg per hour. Preschool and young children, greater than 1 to 2 mLs per kg per hour. And then adolescents, they do say 0.5 to 1 ml per kg per hour or 40 to 80 mLs per hour. Adolescents are similar to adults, so what you learned with your adults would apply. Usually the ranges are generally close. The only notation I want to make is that in clinical practice, we always want to maintain the urine output at 1 ml per kg per hour. So even though the book says, it can go down to 0.5 mLs per kg per hour, in clinical practice, we always make sure it's 1 ml per kg per hour. Okay, and then we don't calculate urine output on every child, but it would be important if the child had came in with dehydration, or if they're receiving an aminoglycoside, then you want to ensure that you have good urine output before giving that those drugs. Also, if you're hanging potassium, you want to make sure that they have really good urine output. So again, you can be looking at calculating urine output, or looking at urine specific gravity, as we talked about in the earlier slide for that. Aminoglycoside administration, you want the urine output to be at least 1 ml per kg per hour. So before administering aminoglycosides, what must be assessed? Did you answer? Did you answer urine output? Good job. Yes, we always want to assess urine output before you hang an aminoglycoside, because we have to make sure that the kidneys are working well. Any drugs that are nephrotoxic, we want to make sure that the kidneys are working well before we hang it. Okay. On those drugs, we will do peak and trough levels, and I'm sure you've heard about this in Med-Surg, but the peak level is obtained after the drug is given, and the trough levels are obtained before the drug is given. And there's therapeutic ranges for the peak and trough levels. The drug levels will vary based on the drug itself. So you do want to look at that, because again, we want to make sure that we're not going to cause any problems. A lot of the drugs can be nephrotoxic, ototoxic, so that can cause hearing loss in that. Okay. So in a neonate, if they're receiving an aminoglycoside, what should be evaluated after therapy? And since I mentioned that they are ototoxic, again, that's toxic to the 8th cranial nerve. So we worry about hearing loss, so they should have a hearing exam done. Okay, and the older patients, you can ask them, do they have any ringing in their ears? If they have any problems with balance, things like that, that can be evaluated also. But usually, like older people are able to tell you, I have ringing in my ears, and whereas a baby can't do that, so they have to have a hearing exam. Okay, so again, usually the peak and trough levels are done around the 3rd dose. They probably told you that in Med-Surg. If the doctor hasn't ordered it, you do want to make sure that the doctors order it because you can be liable if their patient runs into problems with hearing loss in that. So do know your drugs and know when the peak and trough levels should be obtained. And you may have to advocate for that and get the order for that if the physician forgets to do it. So again, remember, if you go ahead and give it and that those levels haven't been done, you can be held liable. Okay. As mentioned previously, the urine-specific gravity, the normal range for a child is 1.010 to 1.020. If the urine-specific gravity is high, that can indicate that they're dehydrated. And if it's low, that can be an indication of overhydration, unless it's an infant. It's not uncommon for an infant to run a lower urine-specific gravity, and that's because they aren't able to concentrate their urine because their kidney function isn't mature. So they might run a urine-specific gravity 1.005, and that's normal for them. So if a child comes in with gastroenteritis, if they've had any nausea, vomiting, dehydration, any reason that they could have any sort of fluid loss, we'd want to check the urine output every void until stable. And stable again would be urine specific gravity 1.010 to 1.020. And then you would do that every shift until discharge. So initially it's every void, and then once they're normal, then do it continue at every shift. They have at Children's a machine that you can check the urine dipstick on, and the urine specific gravity is one of the indicators on the dipstick. So if it's an older child, you can have them pee into the urinal or the hat and then take a syringe and draw it up. You only need a few drops. You don't need a lot of urine. You just drop it on the dipstick and do the recording through the machine with that. As if it's an infant though that is diapered, there's so much gel in the diapers. So, we used to be able to take part of the diaper out and then put that into a syringe and squeeze it out. But now with the gel in the diaper, you can't do that. So you'll need to plan accordingly and get some little gauze to put in the diaper. And then once the gauze is saturated with just urine, it can't have any stool in it, just urine, put that into, take out the plunger of a syringe and put the gauze in there, and then you can squeeze the urine, put the plunger back in and squeeze the urine onto the dipstick for that. Okay. Some special considerations include IV site selection. You probably remember from OB that the most stable site on an infant is in the scalp, and that's because they're usually flailing their arms and legs and that. With young children, we really want to pay attention to what is their dominant hand. Also, if they have a favorite sucky thumb, or young children like toddlers, we tend not to put them in the feet or legs because they're mobile at this age. So again, you want to pay attention to help with when they're starting the IV, know what's an appropriate site that's best for that child's development. IV pumps are used for accuracy. We want to prevent fluid overload. And then medication pumps are also used to deliver medications accurately. We never push any medications. All medications go on a medication pump. You always want to read the original orders and the medication label that's on the medication that you're giving. Sometimes the medications are sent up in with a syringe inside of a um, plastic bag, and we're not giving the plastic bag. So again, you want to take that out, look at the syringe of the medication that you're actually giving, and make sure that you have the correct medication. Because inadvertently, we have found that sometimes the wrong medication gets put in the bag. So just to be safe, always make sure that you check the original orders and make sure that you check the medication labels. For compatibility of solutions and medications, you can find that in drug books. Some of the med rooms have information hanging with compatibility charts in that. In Micromedics, you can also look up compatibility of solutions and medications. And if you can't find the information, you can always call the pharmacist for that. Okay, and then we also already mentioned about hanging potassium. So again, that's a very important consideration that you always want to make sure that you ensure that they have adequate urine output before you hang potassium, and that IV potassium is never given push. It's always given in with IV fluid for that. Pediatric IV fluids, generally infants are D10 and a 0.2 or 0.3. Children can be a D5, 0.2 or 0.3. They may have potassium chloride added after the first void. So again, you'd always want to make sure that you check urine output before you add potassium chloride to that. Okay. Sometimes they'll even do D5.9, and that's fine. And even D5.45 is an appropriate solution for school-age children, adolescents, or any renal patients that sodium waste might need more sodium in with the IV fluid. So the couple of things that I just want you to remember that we generally, you won't see like just a 0.9 hanging or a lactated ringers hanging. If you do, you should question that. You might see a 0.9 hanging with a diabetic, and that would be fine, because they wouldn't need the dextrose generally. So do make sure that you, check for what is appropriate IV fluids. The reason that we go to a D10 on infants is because they have low glucose stores, so they will need a little bit more dextrose. Whereas young children and adolescents and that can tolerate a D5. And again, it would be a 0.2, 0.3, 0.45, or 0.9 with that, and then it can have potassium chloride added to that. Okay, but before you would hang that first bag, if you did have a patient that came in with any sort of dehydration, you'd want to assess urine output for that. Normal saline, we use that to flush peripheral IVs. And if they have a saline lack, you would assess the site hourly and document that in the electronic medical records. Normal saline can also be used as a replacement fluid to replace any losses such as gastric drainage, CSF output from an external ventricular drain, or can be used as urine replacement. Also, if the patient comes in with dehydration and they're going to replace the amount of fluid that's lost, they will run a normal saline fluid. So that's where you'll see normal saline fluid as a replacement fluid, not as a maintenance fluid, if that helps. Total parenteral nutrition. These are some guidelines for when they need to go through a central line. So at Children's, any solution with a dextrose over 12.5%. Some institutions have osmolality listed on their TPN. So if their osmolality is over 600 to 900, then that would need to go through a central line. Central lines are flushed with heparin. You want to carefully read the labels on the heparin with that. Administration and monitoring of TPN. Some of the things that you may or may not have learned is that TPN is always filtered, and then lipids are not filtered. And you should know that TPN or hyperalimentation, whatever you want to call it, is very hard on the liver. So they will get liver function tests will be done weekly. Okay. So when you're starting an initial infusion of TPN, oftentimes they may check blood sugars, especially if it's a small baby, a neonate or a baby. You want to check blood sugars because the to see if they're tolerating the amount of glucose that is added to the TPN. And because usually the renal threshold, if the blood sugar goes above 150 or so, you'll see that they'll spill in their urine. So you can check a urine dipstick to make sure that they're not spilling any glucose in their urine. Okay, so initially they may get blood glucose levels. And then if those are not ordered, then you'd want to dipstick their urine to see if they're spilling glucose. Okay, and that's until they get the solution regulated, and pharmacies involved in that, the doctors in the pharmacy, look at which vitamins and minerals and the amount of glucose in that is put in the hospital for enteral nutrition. Central venous access devices include central lines such as Broviac catheters. They can have infusoports, also called Metaports or Portacath, or they can have peripherally inserted central venous catheters. So a doctor or nurse practitioner who's qualified to insert those will insert PICC lines. And one of the things the point I want to get across is that nurses and our nursing students are not responsible for inserting or discontinuing venous access devices and PICC lines unless it's a nurse that's been certified to do that. Then they can do that with a PICC line. So if you will assist in procedures, and sometimes the lines become infected and they might want to send the tip off for culture. So in that case, you'd want to make sure that you'd get a sterile container and then a sterile suture removal kit. So when they take the line out, you can snip it and put the tip into the sterile container and then send that for culture. Special precautions with PICC lines to prevent complications. We want to remember that they're not sutured in place, so very careful handling. And no blood pressures in the affected extremity, and that goes for all blood pressure, any peripheral blood pressures or PICC lines. We do not do blood pressures in those extremities. So I want you to remember that when you're in clinical practice, because I have seen students that we're trying to take blood pressures in an arm that has a peripheral IV. That's a no-no. Okay, so that's unsafe practice. So do know that no blood pressures in the affected extremity if it's a peripheral IV or if it's a PICC line. Okay, if you're using any stopcocks, they should be in the off position when not used. Especially if it's a central line, because there can be high blood flow and they can have problems with bleeding out through the stopcock. Okay, alligator clamps. If you're using those, make sure that their connection sites are all tightly secured, as with any central line placement. Because we want to prevent accidental blood loss. The main purpose for using a volume control device to administer IV fluids to children is, do you recall what I said earlier? It's to prevent fluid overload. This slide again is a summary slide of important information for you to know. We have the 3 different types of dehydration. And it depends on what textbook you picked up, whether they call it isonatremic or isotonic, hyponatremic, hypotonic, hypernatremic, or hypertonic. I like when they use the term isonatremic because if you remember, natremic means sodium, so that's cueing you into what the sodium is doing. So iso meaning the same, sodium levels are within normal limits. It's the most common type of dehydration is isonatremic dehydration. We see that with fever, vomiting, diarrhea, and it can lead to acute renal failure. Hyponatremic or hypotonic dehydration is where there's water excess with sodium less than 135 milliequivalents per liter. And there can be implications for mixing formula, also drug abuse, and then marathon runners that I just wanted to mention. So it's really important that you teach parents about how to mix formula. And also when they're in pediatrics and they're coming into the hospital or clinic, you would want to assess and make sure that the parents are mixing the formula properly. Because it goes back to what we talked about in some of the first slides, is if they're diluting down the formula, that can actually be very dangerous, and it can lead to hyponatremic dehydration because it's going to be diluting out the sodium, and then the sodium levels can drop and the child or the baby can have a seizure. Okay. Ecstasy, the drug, you've heard instances where people have taken ecstasy and then they drink gobs and gobs of fluids, and then their sodium gets diluted out and they can have seizures and even death related to that. And that would be the same as marathon runners. If they're just drinking water and they're not drinking electrolytes to replace that, the sodium can become low, and that can lead to seizures and even death. So it's really important that you do a good assessment and teaching. There also have been cases of child abuse where the child has been forced to drink water, and the babies can have seizures and succumb to death also. And then you probably, a few years back, you heard about the unfortunate instance where the mom was trying to win some sort of device for the child, and the challenge was to drink water, and the mother died as a result of that. So again, we have to be very cautious, do a lot of teaching with your families and with the public, and make sure that they know that, a lot of times even, with infant formula, parents might think water's benign. They do it because possibly low socioeconomic status and they can't afford the formula. So they dilute down the formula thinking the water is benign, and that's not the case. It can be very harmful to the child. So in these instances, you have to do a good assessment, and then you want to link them up to the services. The WIC program, Women, Infant, and Children, Focus Hope, or any of the supplemental food programs where they can get formula for the baby. Okay, so do a good assessment of psychosocial needs also. And then hypernatremic or hypertonic dehydration is water depletion with sodium greater than 150 milliequivalents per liter. And again, we might see this in the infants and the elderly who have poorly regulated thirst. So they're not getting enough fluids in, and it can also result from fever, GI losses, DKA, and excessive diuretic use. So those are the three types of dehydration, and some things to know about these three types of dehydration. With ice, other things that you want to know about the types of dehydration is how it's replaced, whether it's replaced with rapid replacement or slow replacement of fluid, and the rationale for that. So with isonatremic and hyponatremic dehydration, we use rapid replacement of fluids using an isotonic solution, a 0.9. The fluids are replaced within a 24-hour period. So if you're looking at either the sodium's normal or the sodium's low, and thinking back to the normal maintenance fluids, generally a 0.2 of sodium, 0.2, 0.3, 0.45. Giving a 0.9 is going to give more sodium to help through this dehydration. Okay, and again, the fluids are a rapid replacement because it's given within a 24-hour period. With hypernatremic dehydration, it's slow replacement of fluids using a hypotonic solution. So again, a 0.2, low 0.2 NaCl. And then the fluids are replaced over a 48-hour period. Because of the way water and nutrients move in and out of the brain, we don't want to contribute to cerebral edema. So we want to prevent cerebral edema. So in this type of dehydration, we have to use a slow replacement of fluid. Okay, so again, to recap, isonatremic and hyponatremic dehydration is rapid replacement with an isotonic solution, and the fluids are replaced within 24 hours. And then hypernatremic dehydration is a slow replacement with hypotonic solution. And that's the reason for that is to prevent cerebral edema. Okay, so I do want you to know the different types of dehydration and whether it's rapid or slow replacement of fluids for that. With rapid replacement, there's a couple different ways that we can do this. They can bolus at 10 to 20 mLs per kg, and that's with the 0.9 sodium chloride solution. And then they hang maintenance fluids at 1.5 times maintenance. So when they come in and you give a bolus after when they void, then you would check a urine specific gravity. And if the urine specific gravity is still above 1.020, then approach the physician and see if they can give another bolus of 10 per kilo or 20 per kilo, whatever they decide. You do that until the urine specific gravity comes to within normal, and then they would switch them over to the 1.5 times maintenance. Okay. And some of the books do show where the first half of the deficit is over the first 8 hours, and then the second half of the deficit over the next 16 hours. So you may have an older physician that is still practicing this way, and I'll show you that in the next slide. But generally, now they'll do the bolus. And again, depending on how dehydrated, whether they use 10 or 20 per kilo, and then you check the urine specific gravity. And then determine whether or not they need another bolus. And, once they're within urine-specific gravities within normal stable limits, then we can go to 1.5 times maintenance with the IV maintenance fluids. Okay, so remembering the 0.9 is your replacement fluids. And then after the 0.9 boluses are given, then we look to using the maintenance fluids that were listed in the previous slide. So here's an order showing rapid replacement of fluids using the second method. Now this isn't anything that you need to memorize, but this shows you, how it would be presented. Assessment and monitoring of dehydration. Body weight is compared to fluid loss. Approximately 1 gram of body weight is equal to 1 ml of body fluid. Monitoring parameters would be weight, usually a daily weight. Vital signs we'll talk about when we talk more about the signs of dehydration. We'll look at what the heart rate does, what blood pressure does. We already mentioned, monitoring urine output, urine specific gravity, and how that is affected by the extracellular fluid status. One of the things you also want to remember when you're assessing an infant for dehydration is to check the anterior fontanelle. Now, the posterior fontanelle closes very early, within a few months, whereas the anterior fontanelle remains open for usually, it closes about a year to at the latest about a year and a half. So it's a good indication of hydration status is to be able to palpate the anterior fontanelle. Okay, and when you describe it, you can say soft and flat, and that is normal. If it's like slightly sunken, if you can put your finger in there a little bit, or if it's sunken, then you can say anterior fontanelle slightly sunken or sunken. And if it's bulging, that could indicate fluid overload or hydrocephalus. Okay, so again, you can teach parents about the anterior fontanelle, and again, it's a good assessment of hydration status in infants that needs to be documented, assessed and documented. Fluid volume deficit. So again, we're looking at the severity of dehydration, and that's listed for you. So we have mild dehydration, which is less than 3 to 5% loss of body weight or body fluid. Fluid volume loss of less than 50 mLs per kg. And the urine output can be slightly decreased. With moderate dehydration, there can be a 6 to 10% loss of body fluids and fluid loss of 50 to 100 mLs per kg. So an early assessment finding is tachycardia. So the heart rate might be normal or it might be a little tachycardic, especially as you get into moderate dehydration, you will see that there's a change in the heart rate. Um, with these severe dehydration that's greater than 10% loss of body fluids or body weight, uh, fluid loss of greater than 100 mLs per kg, and a late sign, usually if the patient loses 8 to 10% of their body fluids, a late sign can be a drop in blood pressure. So again, we want to catch it early with the increase in the heart rate. And, if the blood pressure has dropped, then that's a late sign. Okay. And the type of IV replacement fluid. So remember that they oftentimes mild to moderate dehydration can be managed with oral replacement therapy, whereas with severe dehydration, they'll look at replacing it with IV fluids. Okay. And doing the boluses and that as we had mentioned, with the 0.9. There's a comparison chart in your textbook, and you'll need to find the correct pages since there is a new textbook and this has not, we're still using Kyla and Carmen, but the pages may differ slightly. So again, they should be there are the comparison charts and the teaching guidelines. And then the indications for breastfeeding, we still, if they do present, we still allow them to breastfeed. So I'm going to hold you responsible for looking to the book for those charts. Recommended oral rehydration solution for mild to moderate dehydration. The most common that we use is Pedialyte. Sometimes parents may tell you that they'll only drink apple juice. So you'd want to make sure that you dilute it because apple juice has a high osmolality, and especially if they're having diarrhea, that can contribute to the diarrhea. So Gatorade can be used for older children, like school-age children, and that we can use Gatorade. You want to avoid tap water, again, because it doesn't have the minerals in it, and, they can, we don't want to give too much tap water because it can lead to an electrolyte imbalance with that. Soup and broth is too salty. Milk can be cause inflammation and congestion and thickening of the mucus in the respiratory system and the gastrointestinal system. And then colas can be dehydrating because they contain caffeine. So why should sugary beverages or drinks be avoided? And again, that's because of the high osmolality, and that can lead to further the diarrhea. Colas and caffeine should be avoided because they're dehydrating. And then why are small amounts of liquids at room temperature best tolerated? And this goes back to not causing more peristalsis. So if you keep the liquids at room temperature, they're not going to have as much peristalsis. So they'd be less likely to have, it contributing to diarrhea with that. Now we'll talk about acid-base disturbances. These are the normal mean arterial blood gas values that are similar to your adults. These were taken from the Harriet Lane handbook that the physicians use. So the pH is 7.35 to 7.45. PaCO2 is 35 to 45 millimeters of mercury. And the bicarbonate is 22 to 26 milliequivalents per liter. And you always want to put the unit of measurement whenever you're adding any numbers to a chart. Always add the unit of measurement to that. Signs and symptoms of respiratory distress and metabolic acidosis are depression of the central nervous system. And with respiratory acidosis, we know that the pH is decreased, the CO2 is increased, and the bicarbonate is increased, and that the principal disturbance is the increase in CO2. So we commonly see this with the health deviation in pediatrics with an obstructed airway. So the aim of treatment would be to administer bronchodilators, supplemental oxygen or mechanical ventilation if needed, and to stop smoking if it were an adolescent that was smoking. So again, you would be looking at what is the principal disturbance, and then how can we work to correct that. Okay, when we're talking about the different types of acid-base disturbances, what I would like you to know is how they relate to the different medical diagnosis for that. So again, if you had asthma or respiratory distress syndrome, they can have respiratory acidosis. So relating the acid-base disturbance to the medical diagnosis, and then remembering that the aim of treatment is to correct the main problem with the acid-base disturbance. So metabolic acidosis, the pH is decreased, CO2 and bicarbonate are decreased. The principal disturbances is the low bicarbonate, and the most common health deviation in pediatrics is due to diarrhea, where they lose alkalinity and they lose potassium. So again, we want to treat the underlying medical condition and administer sodium bicarb to correct the acidity. The rationale for diarrhea causing metabolic acidosis is listed for you, and I'll have you read through that. Integrative medicine for children and treatment of diarrhea. Again, we use oral rehydration therapy, as we had mentioned before. We want to continue with breastfeeding. Possibly using a lactose formula is now recommended. Before we used to, hold up on feedings. Probiotics are used, so they can be yogurt. They even say buttermilk. I don't really know any, kids that like buttermilk, but probiotics are very helpful if a child has diarrhea with that. So probiotics are very safe, and they can be an effective treatment for infectious diarrhea. And then other considerations would be good hand washing and avoid the overuse of antibiotics. And we do in children also as in adults need to watch for C. difficile. Signs and symptoms of respiratory and metabolic alkalosis are CNS stimulation and excitement. With respiratory alkalosis, the pH is increased, the CO2 and the bicarb are decreased. The principal disturbance is blowing off the CO2. So you can see this in children if they're hyperventilating, if they have really strong emotions, if they're fearful of a procedure, if they're in pain. So the aim of treatment would be to rebreathe the CO2. And then metabolic alkalosis is the pH is increased, the CO2 and the bicarb are also increased, and the principal disturbances is the increase in the bicarbonate. The most common health deviation in children is vomiting. There can be decreased extracellular fluid volume and serum chloride levels resulting from loss of hydrochloric acid and potassium chloride. So the aim of treatment is to treat the underlying medical condition and to correct the electrolyte imbalance. So we do tend to see children with pyloric stenosis because a common finding with that is projectile vomiting, so they will experience metabolic alkalosis. So again, I would like you to relate the different acid-base disturbance to different medical diagnoses as we're going through and learning throughout the 4 weeks that we're in class. The rationale for vomiting causing metabolic alkalosis, again, this is listed for you, and you can read through that. Integrative medicine for children in the treatment of vomiting. There's acupressure can be used, antiemetic medications, and other things that are considered safe and effective can be ginger, chamomile, black tea, slippery elm. The reference for these integrative medicine for children is listed at the bottom, and you would always want to consult with the physician to make sure it's safe based on the child's medical diagnosis. Some of these you may have used maybe with moms who were pregnant, and that also to help if they're having hyperemesis. So here's the what I call a clarification pause. So usually in class I'll stop and then I'll have the students look at their notes and go back and see if there's anything that was unclear to you or anything that you missed. So I'd like you to take the opportunity to, again, look through your notes on any of the lectures that I do. If I don't include this clarification pause slide, I still want you to, on any lecture that you have, if you have any questions, I'm going to post a open discussion forum so that you can post a question if you have, if you missed information or if you wanted clarification on any content of any sort, that you can put that online and we can answer each other. You can go in and answer each other, and I'll come in also and answer those questions. So rather than emailing me separate questions, it's more beneficial that everybody gets the same information. So I'd like you to post that in the open discussion forum. It'll say to clarify questions in that. So again, if I don't include a clarification pause slide in the other presentations, then just remember that you always have the opportunity to ask questions and clarify information for that. Okay. Remember, read, reread, and study. Okay. If you have the more you read and reread and study the information, you'll remember the information better. And then also writing out information like your slides and that, notes and that, rather than typing, because they've done studies and they've found that when you write things out, you actually remember them better than if you're typing up your notes. Okay, so I hope this information helped you. If you, again, have any questions, please let me know. And I hope you enjoy class. Bye now.